Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition, Chapter 6, Maternal Adaptations to Pregnancy. From the moment of conception, changes occur in the pregnant woman's body. These changes are necessary to support and nourish the fetus, prepare the woman for childbirth and lactation, and maintain the woman's health. Pregnant women are often puzzled by the physical and physiological changes and unprepared for associated discomforts. Many women rely on nurses to provide accurate information and compassionate guidance throughout their pregnancy. To respond effectively, nurses should understand not only the physiologic and psychological changes, but also how these changes affect the daily lives of expectant mothers and their families. Physiologic adaptations to pregnancy. Changes in body systems. Although pregnancy challenges each body system to adapt to increasing demands of the fetus, the most obvious changes are in the reproductive system. Reproductive system. Uterus. Growth. The most dramatic change during pregnancy occurs in the uterus, which before conception is a small, pear-shaped organ entirely contained in the pelvic cavity. The non-pregnant uterus weighs up to 70 grams, or 2.5 ounces, and has a capacity of approximately 10 milliliters, 1/3 of an ounce. By term, 38 to 42 weeks of gestation, the uterus weighs 1,100 to 1,200 grams, 2.4 to 2.6 pounds, and has a capacity of 5 liters. Uterine growth occurs as the result of hyperplasia and hypertrophy. Growth can be predicted for each trimester, one of 3 13-week periods of pregnancy. Early in pregnancy, growth results from hyperplasia caused by estrogen and growth factors. In the latter half of pregnancy, uterine growth results mainly from hypertrophy as the muscle fibers stretch in all directions to accommodate the growing fetus. In addition to muscle growth, fibrous tissue accumulates in the outer muscle layer of the uterus, and the amount of elastic tissue increases. These changes greatly increase the strength of the muscle wall. Muscle fibers in the myometrium increase in both length and width. Although the uterine wall thickens during early pregnancy, the wall of the uterus thins to approximately 0.5 to 1 centimeter, 0.2 to 0.4 inch, and the fetus can be palpated easily through the abdominal wall by term. As the uterus expands into the abdominal cavity, it displaces the intestines upward and laterally. The uterus gradually rotates to the right as a result of pressure from the rectosigmoid colon on the left side of the pelvis. Pattern of uterine growth. The uterus grows in a predictable pattern that provides information about fetal growth. Figure 6.1. This growth helps confirm the estimated date of delivery, EDD, sometimes called the estimated date of birth, EDB, or estimated date of confinement, EDC. By 12 weeks of gestation, the fundus can be palpated above the symphysis pubis. At 16 weeks, the fundus reaches midway between the symphysis pubis and the umbilicus. It is located at the umbilicus at 20 weeks. The fundus reaches its highest level at the xiphoid process at 36 weeks of gestation. It pushes against the diaphragm, and the expectant mother may experience shortness of breath, even during rest. By 40 weeks, the fetal head descends into the pelvic cavity, and the uterus sinks to a lower level. This descent of the fetal head is called lightening because it reduces pressure on the diaphragm and makes breathing easier. Lightening is more pronounced in first pregnancies. Contractility. Throughout pregnancy, the uterus undergoes irregular contractions called Braxton-Hicks contractions. During the contractions, the uterus temporarily tightens and then returns to its original relaxed state. During the first 2 trimesters, the contractions are infrequent and usually not felt by the woman. Contractions occur more frequently during the 3rd trimester and may cause some discomfort. They are called false labor when they are mistaken for the onset of early labor and fail to result in cervical change. Uterine blood flow. As the uterus enlarges, an increase in the size and diameter of blood vessels expand blood flow dramatically. As pregnancy progresses, the delivery of materials needed for fetal growth and the removal of metabolic wastes depends on adequate perfusion of the placental intervillous spaces. During late pregnancy, blood flow to the uterus and placenta reaches 1,200 milliliter per minute and is 17% of maternal cardiac output. Almost 90% of the blood goes to the placenta. Maternal blood carried by the myometrial arteries enters the intervillous spaces, where oxygen and nutrients are transferred to the chorionic villi and hence to the fetus. Metabolic wastes from the fetus diffuse into venous structures of the mother. See Chapter 5. Cervix. The cervix also undergoes significant changes after conception. Water content and vascularity of the area increase. The most obvious changes occur in color and consistency. Increasing levels of estrogen cause hyperemia, congestion with blood, of the cervix, resulting in the characteristic bluish purple that extends to include the vagina and labia. This discoloration, referred to as Chadwick's sign, is one of the earliest signs of pregnancy. The cervix is largely composed of connective tissue that softens when the collagen fibers decrease in concentration. Before pregnancy, the cervix has a consistency similar to the tip of the nose. After conception, the cervix feels more like the lips or earlobe. The cervical softening is referred to as the Goodell's sign. A less obvious change occurs as the cervical glands proliferate during pregnancy, and the glandular walls become thin and widely separated. As a result, the endocervical tissue resembles a honeycomb that fills with mucus secreted by the cervical glands. The mucus, which is rich in immunoglobulins, forms a plug in the cervical canal, figure 6.2. It blocks the ascent of bacteria from the vagina into the uterus during pregnancy to help protect the fetus and the uterine membranes from infection. The mucus plug remains in place until term, when the cervix begins to thin and dilate, allowing the mucus plug to be expelled. One of the earliest signs of labor may be bloody show, which consists of the mucus plug and a small amount of blood. Bleeding is produced by disruption of the cervical capillaries as the mucus plug is dislodged when the cervix begins to thin and dilate. Vagina and vulva. Increased vascularity causes the vaginal walls to appear bluish purple. Softening of the abundant connective tissue allows the vagina to distend during childbirth. The vaginal mucosa thickens, and vaginal rugae, or folds, become very prominent. Vaginal cells contain increasing amount of glycogen, which causes rapid sloughing and increased thick white vaginal discharge. The pH of the vaginal discharge is acidic, 3.5 to 6. Because of the increased production of lactic acid that results from the action of Lactobacillus acidophilus on glycogen in the vaginal epithelium. The acidic condition helps prevent growth of harmful bacteria in the vagina. However, the glycogen-rich environment favors the growth of Candida albicans, and persistent yeast infections, candidiasis, are common during pregnancy. Increased vascularity, edema, and connective tissue changes make the tissues of the vulva and perineum more pliable. Pelvic congestion during pregnancy can lead to heightened sexual interest and increased orgasmic experiences. Ovaries. Progesterone, called the hormone of pregnancy, must be present in adequate amounts from the earliest stages to maintain pregnancy. Progesterone helps suppress contractions of the uterus and also may help prevent tissue rejection of the fetus. After conception, the corpus luteum of the ovaries secretes progesterone, mainly during the first 6 to 7 weeks of pregnancy. Between 6 and 10 weeks of gestation, the corpus luteum produces a smaller amount of progesterone as the placenta takes over production. The corpus luteum then regresses because it is no longer needed. Ovulation ceases during pregnancy because the high circulating levels of estrogen and progesterone inhibit the release of follicle-stimulating hormone, FSH, and luteinizing hormone, LH, which are necessary for ovulation. Breasts. During pregnancy, the breasts change in both size and appearance. Figure 6.3. Estrogen stimulates the growth of mammary ductal tissue, and progesterone promotes the growth of the lobes, lobules, and alveoli. The breasts become highly vascular, with a delicate network of veins often visible just beneath the surface of the skin. If the increase in breast size is extensive, striations, or stretch marks, similar to those that occur on the abdomen, may develop. Characteristic changes in the nipples and areola occur during pregnancy. The nipples increase in size and become darker and more erect, and the areola become larger and more pigmented. The degree of pigmentation varies with the complexion of the expectant mother. Women with very light skin tones exhibit less change in pigmentation than those with darker skin. Sebaceous glands, called tubercles of Montgomery, become more prominent during pregnancy and secrete a substance that lubricates the nipples. In addition, a thick, yellowish fluid, colostrum, is secreted as early as 16 weeks of gestation. Secretion of milk is suppressed during pregnancy by the high levels of estrogen and progesterone. Cardiovascular system. During pregnancy, alterations occur in heart size and position, blood volume, blood flow, and blood components. Heart size and position. Changes in the size and position of the heart are minor and reverse soon after childbirth. The muscles of the heart, myocardium, enlarge 10% to 15% during the first trimester. The heart is pushed upward and to the left as the uterus elevates the diaphragm during the third trimester. As a result of the change in position, the locations for auscultation of heart sounds may be shifted upward and laterally in late pregnancy. Heart sounds. Some heart sounds may be so altered during pregnancy that they would be considered abnormal in the non-pregnant state. The changes are first heard between 12 to 20 weeks and continue for 2 to 4 weeks after childbirth. The most common variations in heart sounds include splitting of the first heart sound and a systolic murmur that is found in more than 95% of pregnant women. The murmur is best heard at the left sternal border. Up to 90% of pregnant women have a third heart sound. Blood volume. Total blood volume increases significantly because of a combination of plasma and components such as red blood cells, RBCs, erythrocytes, white blood cells, WBC, leukocytes, and platelets, thrombocytes. Total blood volume increase begins by week 6 of gestation and reaches an average of 30% to 45% during pregnancy. The increased volume is needed to 1. Transport nutrients and oxygen to the placenta, where they become available for the growing fetus, 2. Meet the demands of the expanded maternal tissue in the uterus and breasts, and 3. Provide a reserve to protect the pregnant woman from the adverse effects of blood loss that occur during childbirth. Plasma volume. Plasma volume increases from 6 to 8 weeks until 32 weeks of gestation. The plasma volume is 40% to 60%, 12 to 1600 milliliters, greater than in non-pregnant women. The increase is higher in multifetal pregnancies. The reason for the increase is unclear, but it may be related to vasodilation from nitric oxide and to estrogen, progesterone, and prostaglandin stimulation of the renin-angiotensin-aldosterone system, which causes sodium and water retention. Red blood cell volume. RBC volume increases by approximately 20 to 30% above pregnancy values. Although both RBC volume and plasma volume expand, the increase in plasma volume is more pronounced and occurs earlier. The resulting dilution of RBC mass causes a decline in maternal hemoglobin and hematocrit. This condition is frequently called physiologic anemia of pregnancy, or pseudoanemia of pregnancy, because it reflects dilution of RBCs in the expanded plasma volume rather than actual decline in the RBCs and does not indicate true anemia. Physiologic anemia should not be dismissed as unimportant, however. Frequent laboratory examinations may be needed to distinguish between physiologic and true anemia. Generally, iron deficiency anemia occurs when the hemoglobin is less than 11 grams per deciliter in the first and third trimesters, or less than 10.5 grams per deciliter in the second trimester. Iron supplementation is often prescribed for all pregnant women by the second trimester to prevent anemia. Dilution of RBCs by plasma may have a protective function. By decreasing blood viscosity, dilution may counter the tendency to form clots that could obstruct blood vessels and cause serious complications. Hemodilution may also increase placental perfusion. Cardiac output. The expanded blood volume of pregnancy results in an increase in cardiac output, the amount of blood ejected from the heart each minute. It is based on stroke volume, the amount of blood pumped from the heart with each contraction, and heart rate, the number of times the heart beats each minute. Cardiac output increases 30% to 50%, with half of the rise occurring in the first 8 weeks of pregnancy and remains elevated throughout pregnancy. The increase in cardiac output is a result of a gain in stroke volume and a heart rate acceleration that peaks at 15 to 20 beats per minute, BPM, by 32 weeks of gestation. Cardiac output is highest when the woman is lying on her side and is lower in the standing and supine positions. Systemic vascular resistance. Systemic vascular resistance falls during pregnancy. This change is likely because of 1. Vasodilation resulting from the effects of progesterone and prostaglandins, 2. The addition of the uteroplacental unit, which provides a greater area for circulation and low resistance, 3. Increased heat production from fetal, placental, and maternal metabolism, which produces vasodilation, 4. Decreased sensitivity to angiotensin II, and 5. Endothelial prostacyclin and endothelial-derived relaxing factors, such as nitric oxide. Blood pressure. Blood pressure is an indirect measurement of the systemic vascular resistance. Due to the increased blood volume, the blood pressure changes during pregnancy are minimal. The diastolic pressure decreases slightly, about 10 to 15 millimeters of mercury, due to the influence of progesterone. This begins at 6 weeks of pregnancy and is most noticeable by the beginning of the third trimester. Effective position and other variables. An accurate BP is affected by the maternal position. Systolic pressure remains largely unchanged or decreases slightly if it is measured when the woman is sitting or standing. Arterial pressures are approximately 10 millimeters of mercury lower when the pregnant woman is in a side-lying or in supine position than when she is sitting or standing. The most accurate and therefore preferred measurement is obtained with the woman in a sitting position. The position of the arm can make a difference in the reading. The arm should be at the level of the heart. If the arm is above the heart, the reading will be lower. If the arm is below the heart, the reading will be higher. The size of the cuff can affect the reading. A small cuff will show a higher reading, and a large cuff will show a lower reading. It is important at every prenatal visit to measure the blood pressure with the woman in a seated position and using the appropriate cuff size. In addition, the same arm and position should be used consistently. These variables should be documented with the blood pressure reading. Blood pressure can also be affected by age, activity, anxiety, chronic health conditions, pain, smoking, or use of alcohol or medications. Supine hypotension. When the pregnant woman is in the supine position, particularly in late pregnancy, the weight of the gravid, pregnant, uterus partially occludes the vena cava and the aorta, figure 6.4. The occlusion diminishes return of blood from the lower extremities and consequently reduces cardiac return. Cardiac output may be reduced 25 to 30% when the woman is in this position. As many as 5 to 10% of women develop a drop in BP known as supine hypotensive syndrome, with symptoms of lightheadedness, dizziness, nausea, or syncope, a brief lapse in consciousness. When in the supine position, blood flow through the placenta also decreases if the woman remains in the supine position for a prolonged time, which could result in fetal hypoxia. Turning the woman to a lateral recumbent position alleviates the pressure on the blood vessels and quickly corrects supine hypotension. Women should be advised to rest in the sideline position to prevent or correct the occurrence of supine hypotension. If they must lie in the supine position for any reason, a wedge or pillow under one hip may be effective in decreasing supine hypotension. Blood flow. 5 major changes in blood flow occur during pregnancy. Blood flow is altered to include the uroplacental unit. Renal plasma flow increases up to 30% to remove the increased metabolic wastes generated by the mother and fetus. The woman's skin requires increased circulation to dissipate heat generated by increased metabolism during pregnancy. Blood flow to the breasts increases, resulting in engorgement and dilated veins. And the weight of the expanding uterus on the inferior vena cava and iliac veins partially obstructs blood return from veins in the legs. Blood pools in the deep and superficial veins of the legs, causing venous dissension. Prolonged engorgement of the veins of the lower legs may lead to varicose veins of the legs, vulva, or rectum, hemorrhoids. Blood components. Although iron absorption is increased during pregnancy, sufficient iron is not always supplied by the diet. Iron supplementation is necessary to promote hemoglobin synthesis and ensure erythrocyte production adequate to prevent iron deficiency anemia. Leukocytes increase during pregnancy, ranging from 5,000 cells per cubic milliliter to 12,000 cells per cubic milliliter, or as high as 15,000 cells per cubic milliliter. Leukocytes increase further during labor and the early postpartum period, reaching levels of 25,000 cells per cubic milliliter to 30,000 cells per cubic milliliter. Pregnancy is a hypercoagulable state because of increase in factors that favor clotting and a decrease in factors that inhibit clotting. Fibrinogen, factor 1, fibrin, split products, and factors 7, 8, 9, and 10 rise by 50%. These changes increase the ability to form clots. Fibrinolytic activity to break down clots decreases during pregnancy. The platelet count may decrease slightly, but generally remains within the normal range. These changes offer some protection from hemorrhage during childbirth, but also increase the risk for thrombus formation. The risk is a concern if the woman must stand or sit for prolonged periods, with stasis of blood in the veins of the legs. Respiratory system. The major respiratory changes in pregnancy are the result of 3 factors: increased oxygen consumption, hormonal factors, and the physical effects of the enlarging uterus. Oxygen consumption. Oxygen consumption rises by 20% in pregnancy. Half the increase is used by the uterus, the fetus, and the placenta, 30% by the heart and kidneys, and the rest by the respiratory muscles and breast tissues. The tidal volume, the volume of gas moved into or out of the respiratory tract with each breath, increases by 30 to 40%. Although residual volume decreases by 20%, total lung capacity decreases by only 4%. To compensate for the increased need, progesterone causes the woman to hyperventilate slightly by breathing more deeply, although her respiratory rate remains unchanged. The partial pressure of carbon dioxide, PCO2, decreases. Increased excretion of hydrogen ions from the kidneys partially compensates for the resulting mild respiratory alkalosis. The hyperventilation and respiratory alkalosis facilitate transfer of carbon dioxide from the fetus to the mother. Hormonal factors. Progesterone. Progesterone is considered a major factor in the respiratory changes of pregnancy. Progesterone, along with prostaglandins, helps decrease airway resistance by up to 50% by relaxing the smooth muscle in the respiratory tract. Progesterone is also believed to increase the sensitivity of the respiratory center in the medulla oblongata to carbon dioxide, thus stimulating the increase in minute ventilation. These 2 factors are responsible for the heightened awareness of the need to breathe, shortness of breath, and increased respirations experienced by many women during pregnancy. Estrogen. Estrogen causes increased vascularity of the mucous membranes of the upper respiratory tract. As the capillaries become engorged, edema and hyperemia develop within the nose, pharynx, larynx, and trachea. This congestion may cause nasal and sinus stuffiness, epistaxis, nosebleed, and deepening of the voice. Increased vascularity also causes edema of the eardrum and eustachian tubes and may result in a sense of fullness in the ears. Physical effects of the enlarging uterus. During pregnancy, the enlarging uterus lifts the diaphragm approximately 4 centimeters, 1.6 inches. The elevation of the diaphragm does not impede its movement, which is increased by about 1 to 2 centimeters during respirations. The ribs flare, the substernal angle widens, and the transverse diameter of the chest expands by about 2 centimeters, or 0.8 inches, to compensate for the reduced space. These changes begin when the uterus is just beginning to enlarge. They result from the hormone relaxin, which causes relaxation of the ligaments around the ribs. Breathing becomes thoracic rather than abdominal, adding to the dyspnea that as many as 60 to 70% of women experience beginning in the first or second trimester. Gastrointestinal system. The GI system undergoes changes that are clinically significant because they can cause discomfort for the expectant mother. Appetite. Unless the woman is nauseated, her appetite is often increased during pregnancy. This helps her consume the additional calories recommended. Food intake may increase by 15 to 20% beginning in early pregnancy. Mouth. Elevated levels of estrogen cause hyperemia of the tissues of the mouth and gums and may lead to gingivitis and bleeding gums. Some women develop a high vascular hypertrophy of the gums called epulis. The condition regresses spontaneously after childbirth. Although the amount of saliva does not usually change, some women experience ptyalism or excessive salivation. The cause of ptyalism may be decreased swallowing, associated with nausea and stimulation of the salivary glands by the ingestion of starch. Small frequent meals and use of chewing gum and oral lozenges offer limited relief to some women. Many women think that pregnancy causes loss of minerals from teeth to meet fetal needs. However, this is not true, and the tooth enamel is stable during pregnancy. Tooth decay may occur because of changes in saliva and the nausea and vomiting of pregnancy. Periodontal disease may result in infections that precipitate preterm labor. Esophagus. The lower esophageal sphincter tone decreases during pregnancy, primarily because of the relaxant activity of progesterone on the smooth muscles. These changes, along with upward displacement of the stomach, allow gastroesophageal reflux of acidic stomach contents into the esophagus and produces heartburn. Stomach. Elevated levels of progesterone relax all smooth muscle, decreasing tone and motility of the GI tract. The effect of emptying time of the stomach is unclear, with some studies showing a decrease and others showing no change during pregnancy. Gastric acidity is decreased during the first 2 trimesters and increased during the 3rd trimester. The risk for gastric ulcers decreases during pregnancy. Large and small intestines. Emptying time of the intestines increases, allowing more time for nutrient absorption. It also may cause bloating and abdominal distension. Calcium, iron, some amino acids, glucose, sodium, and chloride are better absorbed during pregnancy, but absorption of some of the B vitamins is reduced. Decreased motility in the large intestine allows time for more water to be absorbed, leading to constipation. Constipation may cause or exacerbate hemorrhoids if the expectant mother must strain to have bowel movements. Flatulence also may be a problem. Liver and gallbladder. Although the size of the liver and gallbladder remains unchanged during pregnancy, estrogen and progesterone cause functional changes. The enlarging uterus pushes the liver upward and backward during the last trimester, and liver function is also altered. The serum alkaline phosphatase level rises 2 to 4 times that in the non-pregnant woman. Serum albumin and total protein fall, partly because of hemodilution. The gallbladder becomes hypotonic and emptying time is prolonged. The bile becomes thicker, predisposing to the development of gallstones. Reduced gallbladder tone also leads to a tendency to retain bile salts, which can cause itching. Urinary system. Bladder. The woman experiences frequency and urgency of urination throughout her pregnancy. Although uterine expansion within the pelvis is one cause of these urinary changes, frequency begins before the uterus is big enough to exert pressure on the bladder. Hormonal influences, increased blood volume, and changes in renal blood flow and glomerular filtration rate, GFR, may play a significant role in urinary frequency. Stress and urge incontinence begin at any time during pregnancy and continue until after delivery is experienced by 30 to 50% of pregnant women. Although frequency and urgency are normal during pregnancy, there are also signs of infection, and, if accompanied by burning sensation or pain, may indicate UTI. Bladder capacity doubles by term, and the tone is decreased in response to progesterone. Nocturia is common because sodium and water are retained during the day and excreted during the night when the woman is lying down. Pressure from the uterus pushes the base of the bladder forward and upward near the end of pregnancy. The bladder mucosa becomes congested with blood, and the bladder walls become hypertrophied as a result of stimulation from estrogen. Decreased drainage of blood from the base of the bladder results in edema of its tissues and renders the area susceptible to trauma and infection during childbirth. Kidneys and ureters. Changes in size and shape. During pregnancy, the kidneys change in both size and shape because of dilation of the renal pelvis, calces, and ureters above the pelvic brim. The dilation begins during the second month of pregnancy. The ureters become elongated and are compressed between the enlarging uterus and the bony pelvic brim. The flow of urine through the ureters is partially obstructed, causing hydrostatic pressure against the renal pelvis. This occurs especially on the right side because the ureter turns toward the right during pregnancy and crosses the iliac and right ovarian veins. As much as 300 milliliters of urine may be present in the ureters. The resulting stasis of urine is important because it allows time for bacteria to multiply. The risk for bacteriuria, which may be asymptomatic, is increased, and pyelonephritis results in 30% of these women. Functional changes of the kidneys. Renal plasma flow increases by 50% to 80% during pregnancy. This change results from increases in plasma volume and cardiac output. The flow is highest when the woman is in the left side-lying position. The GFR rises by as much as 50% because of the higher renal blood flow. The increases in renal plasma flow and GFR are necessary for excretion of additional metabolic waste from the mother and the fetus. Glucose excretion increases, and glycosuria or glucoseuria is common during pregnancy. Small quantities of amino acids, water-soluble vitamins, and electrolytes are also excreted because the filtered load of these substances exceeds the ability of the renal tubules to reabsorb them. Bacteria thrive in urine that is rich in nutrients, increasing the risk for urinary tract infections and during pregnancy. Urine output increases throughout pregnancy. Mild proteinuria is common and does not necessarily indicate abnormal kidney function or preeclampsia. Protein level may be monitored throughout pregnancy to identify increases that would indicate a problem. Tests of renal function may be misleading during pregnancy. As a result of increased GFR, serum creatinine and blood urea nitrogen decrease, and creatinine clearance levels increase. Integumentary system. Skin. Circulation to the skin increases to help dissipate excess heat produced by increased metabolism. Pregnant women feel warmer and perspire more, particularly during the last trimester. Accelerated activity by the sebaceous glands fosters the development of acne. Additional changes include hyperpigmentation and vascular changes in the skin. Hyperpigmentation. Increased pigmentation from elevated levels of estrogen, progesterone, and melanocyte-stimulating hormone occurs in 91% of pregnant women. Women with dark hair or skin exhibit more hyperpigmentation than women with very light coloring. Areas of pigmentation include brownish patches called melasma, chloasma, or the mask of pregnancy. Melasma include the forehead, cheeks, and bridge of the nose and occurs in approximately 70% of pregnant women. It also may occur in non-pregnant women taking oral contraceptives. Melasma increases with exposure to sunlight, but use of sunscreen may reduce the severity. Although melasma usually resolves after delivery when estrogen and progesterone levels decline, it continues for months or years in about 30% of women. The linea alba, the line that marks the longitudinal division of the midline in the abdomen, darkens to become the linea nigra. This dark line of pigmentation may extend from the symphysis pubis to as high as the top of the fundus. Pre-existing moles, nevi, freckles, and the areolae become darker as pregnancy progresses. Hyperpigmentation usually disappears after childbirth. Cutaneous vascular changes. During pregnancy, blood vessels dilate and proliferate, which is an effect of estrogen. Changes in surface blood vessels are obvious during pregnancy, especially in women with fair skin. Vascular spiders, or telangiectasia, that appear as tiny red elevations branching in all directions and occur most often on areas exposed to the sun. Redness of the palms of the hands or soles of the feet, known as palmar erythema, also occurs in many white women and some African American women. Vascular changes may be emotionally distressing for the expectant mother, but they are clinically insignificant and usually disappear shortly after childbirth. Connective tissue. Linear tears may occur in the connective tissue, most often on the abdomen, breasts, and buttocks, appearing as slightly depressed pink to purple streaks called striae gravidum, or stretch marks, figure 6.6. They occur in 50 to 80% of pregnant women, and 10% have severe striae. Women are concerned about striae because they do not disappear after childbirth, although the marks usually fade to silvery lines. Laser therapy is sometimes used after childbirth to reduce or eliminate severe striae. Many women believe that striae can be prevented by massaging with oil, vitamin E, or cocoa butter, but these substances have not been found effective. Antipruritic creams may be effective in controlling the itching that often occurs. Hair and nails. Because fewer follicles are in the resting phase, hair grows more rapidly and less hair falls out during pregnancy. After childbirth, hair follicles return to normal activity, and many women become concerned at the rate of hair loss that occurs 2 to 4 months after childbirth. They need reassurance that more follicles have returned to the normal resting phase and excessive hair loss will not continue. Hair growth returns to normal within 6 to 12 months after childbirth. Nails may become brittle or softer, or may develop transverse grooves. Some women's nails grow faster or split or break more easily during pregnancy. These changes end after childbirth, and no treatment is needed. Musculoskeletal system. Calcium storage. During pregnancy, fetal demands for calcium increase, especially in the third trimester. Absorption of calcium from the intestine doubles during pregnancy. Calcium is stored for use during the third trimester when fetal needs peak. Although 28 to 30 grams of calcium from maternal bone stores is transferred to the fetus, this amount is small compared with total maternal stores and does not deplete the maternal bone density. Postural changes. Musculoskeletal changes are progressive. They begin early in pregnancy when relaxin and progesterone initiate relaxation of the ligaments. At 28 to 30 weeks, the pelvic symphysis separates. The increased mobility of the pelvic joints causes the pregnant woman to assume a wide stance with the waddling gait of pregnancy. During the third trimester, as the uterus increases in size, the expectant mother must lean backward to maintain her balance. This posture creates a progressive lordosis or curvature of the lower spine and often leads to backache. Obesity or previous back problems increase the problem. Abdominal wall. The abdominal muscles may be stretched beyond their capacity during the third trimester, causing diastasis recti, separation of the rectus abdominis muscles. The extent of the separation varies from slight and clinically insignificant to severe, when a large portion of the uterine wall is covered only by the peritoneum, fascia, and skin. Endocrine system. Numerous changes in hormones occur in pregnancy, table 6.1. Pituitary gland. The anterior pituitary gland increases in size during pregnancy. Serum prolactin levels increase tenfold by term to prepare the breasts for lactation. The hormones FSH and LH are not needed to stimulate ovulation during pregnancy and are suppressed by high levels of estrogen and progesterone. The posterior pituitary releases oxytocin, which stimulates contractions of the uterus. This action is inhibited by progesterone, produced mainly by the placenta during pregnancy. In the second half of pregnancy, estrogen causes a gradual rise of oxytocin receptors in the uterus, increasing contractions near term. After childbirth, oxytocin plays an important role in keeping the uterus contracted to prevent excessive bleeding. Oxytocin also stimulates the milk ejection reflex after childbirth. Thyroid gland. Hyperplasia and increased vascularity cause the thyroid gland to enlarge during pregnancy. The availability of thyroid hormones increases by 40 to 100%. Early in the first trimester, a rise in total thyroxine T4 and thyroxine binding globulin occurs. Levels of serum unbound or free T4 rise early in pregnancy, but return to normal non-pregnant levels by the end of the first trimester. Both T4 and triiodothyronine T3 cross the placenta. Maternal thyroid hormones are important for fetal neurologic function because the fetus does not synthesize thyroid hormones until 10 to 12 weeks of gestation. Parathyroid glands. Parathyroid hormone, which is important in calcium homeostasis, is decreased by 10 to 30% in the first trimester and increases by term. However, it remains in the normal range throughout pregnancy. Calcium supplies for transfer to the fetus are adequate. Pancreas. Significant changes in the pancreas during pregnancy are the result of alterations in maternal blood glucose levels and fluctuations in insulin production. Blood glucose levels are 10 to 20% lower than before pregnancy, and hypoglycemia may develop between meals and at night as the fetus continuously draws glucose from the mother. During the second half of pregnancy, maternal tissue sensitivity to insulin begins to decline because of the effects of human chorionic somatomammotropin, HCS, prolactin, estrogen, progesterone, and cortisol. The mother uses fatty acids to meet energy needs. Fasting blood glucose level is decreased as glucose passes to the fetus. Postprandial, after a meal, blood glucose level is higher than before pregnancy because of insulin resistance, making more glucose available for fetal energy needs. In healthy women, the pancreas produces additional insulin. In some women, however, insulin production cannot be increased, and these women experience periodic hyperglycemia or gestational diabetes. See Chapter 10. Adrenal glands. Although the adrenal glands enlarge only slightly during pregnancy, significant changes occur in two adrenal hormones, cortisol and aldosterone. The concentrations of both serum cortisol and free, unbound cortisol, the metabolically active form, are higher. The increase is the result of the elevated estrogen level and a decrease in metabolic clearance rate, doubling the half-life of cortisol. Cortisol regulates carbohydrate and protein metabolism. It stimulates gluconeogenesis, formation of glycogen from non-carbohydrate sources such as amino and fatty acids, whenever the supply of glucose is inadequate to meet the body's needs for energy. Aldosterone regulates the absorption of sodium from the distal tubules of the kidneys. It increases very early in pregnancy to overcome the salt-wasting effects of progesterone. This helps maintain the necessary level of sodium in the greatly expanded blood volume to meet the need of the fetus. Aldosterone level is closely related to water metabolism. Change is caused by placental hormones. Human chorionic gonadotropin. In early pregnancy, human chorionic gonadotropin, HCG, is produced by the trophoblastic cells surrounding the developing embryo. The primary function of HCG in early pregnancy is to prevent deterioration of the corpus luteum so it can continue producing estrogen and progesterone until the placenta is sufficiently developed. The presence of this hormone produces a positive pregnancy test result. Estrogen. Early in pregnancy, estrogen is produced by the corpus luteum. The placenta produces estrogen for the remainder of pregnancy. The effects of estrogen during pregnancy can include the following: suppression of FSH and LH, stimulation of uterine growth, increased blood supply to uterine vessels, added deposit of maternal fat stores to produce a reserve of energy, increased uterine contractions near term, development of the glands and ductal system in the breasts in preparation for lactation, hyperpigmentation, stimulation of vascular changes in the skin, breasts, upper respiratory tract, and bladder, antagonist to insulin. Progesterone. Progesterone is produced first by the corpus luteum and then by the fully developed placenta. Progesterone is the most important hormone of pregnancy. Its major effects include suppression of FSH and LH, maintenance of the endometrial layer for implantation of the fertilized ovum, and prevention of menstruation, decreased uterine contractility to prevent spontaneous abortion, increased fat deposits, stimulation of development of the lobes, lobules, and ducts in the breast for lactation, relaxation of smooth muscles of the uterus, gastric sphincter, bowels, ureters, bladder, increased respiratory sensitivity to carbon dioxide, stimulating ventilation, suppression of the immunologic response, preventing rejection of the fetus, antagonist to insulin, retention of sodium. Human chorionic somatomammotropin, also called human placental lactogen, HPL, human chorionic somatomammotropin, HCS, is present early in pregnancy and increases steadily throughout pregnancy. Its primary function is to increase the availability of glucose for the fetus. A potent insulin antagonist, HCS reduces the sensitivity of maternal cells to insulin and decreases maternal metabolism of glucose. This frees glucose for transport to the fetus, who needs a constant supply. In addition, HCS encourages the quick metabolism of free fatty acids to provide energy for the pregnant woman. HCS also helps prepare the breasts for lactation and may act as a growth hormone. Relaxin. Relaxin is produced by the corpus luteum, the decidua, and the placenta, and is present by the first missed menstrual period. Relaxin inhibits uterine activity, softens connective tissue in the cervix, and relaxes cartilage and connective tissue to increase mobility of the pelvic joints. Changes in metabolism. During pregnancy, approximately 3.5 kilograms of fat and 30,000 kilocal are accumulated. In addition, the woman, fetus, and placenta synthesize 900 grams of new protein. The basal metabolic rate increases 10% to 20% by the third trimester. Weight gain. A correlation exists between inadequate weight gain in pregnancy and small for gestational age infants, as well as between excessive weight gain and increased risk for large for gestational age infants. Therefore, women of normal pre-pregnancy weight are encouraged to gain an average of 11.5 to 16 kilograms, 25 to 35 pounds, during pregnancy. The fetus, placenta, and amniotic fluid make up less than half the recommended weight gain. The remainder is found in the increased size of the uterus and breasts, increased blood volume, increased interstitial fluid, and maternal stores of subcutaneous fat. Water metabolism. The amount of water needed during pregnancy increases to meet the needs of the fetus, placenta, amniotic fluid, and increased blood volume. Total body water increases by 6.5 to 8.5 liters by term. The kidneys must compensate for the many factors that influence fluid balance. Increased GFR, prostaglandins, decreased concentration of plasma proteins, and increased progesterone level all result in an increase in sodium excretion. However, increased concentrations of estrogen, deoxycorticosterone, HCS, and aldosterone all tend to promote the reabsorption of sodium. The net effect of the combined hormonal action is the maintenance of the sodium and water balance. Edema. Because of hemodilution, colloid osmotic pressure decreases slightly, which favors the development of edema during pregnancy. Edema further increases toward term when the weight of the uterus compresses the veins of the pelvis. This process delays venous return, causing the veins of the legs to become distended, and increases venous pressure, resulting in additional fluid shifts from the vascular compartment to interstitial spaces. Up to 70% of women have dependent edema during pregnancy. Accumulation of 2 liters or more of fluid occurs with edema of the feet. The edema is obvious at the end of the day, particularly if a pregnant woman stands for prolonged periods, and the force of gravity contributes to the pooling of blood in the veins of the legs. Generalized edema occurs if women retain 4 to 5 liters of water. Dependent edema is clinically insignificant if no other abnormal signs are present. Carbohydrate metabolism. Carbohydrate metabolism changes markedly during pregnancy when more insulin is needed as pregnancy progresses as a result of increased insulin resistance. Sensory organs. Eye. Corneal edema may cause women who wear contact lenses to have some discomfort. The problem resolves after childbirth, and women should not get new prescriptions for lenses for several weeks after delivery. Intraocular pressure decreases, which may cause improvement and a need for less medication in women with glaucoma. Ear. Changes in the mucous membranes of the eustachian tube from increased levels of estrogen may cause women to have blocked ears and a mild temporary hearing loss. Immune system. Immune function is altered during pregnancy to allow the fetus, which is foreign tissue for the mother, to grow undisturbed without being rejected by the woman's body. This may cause autoimmune conditions such as rheumatoid arthritis and multiple sclerosis to improve during pregnancy. Resistance to some infections is decreased, however, and some viral and fungal infections occur more often during pregnancy. Confirmation of pregnancy. Although many women undergo early ultrasonography to confirm the pregnancy, the diagnosis of pregnancy has traditionally been based on symptoms experienced by the woman as well as signs observed by a physician, nurse midwife, or nurse practitioner. Figure 6.8 summarizes maternal changes that occur throughout pregnancy. See Chapter 5 for a discussion on fetal growth and development. The signs and symptoms of pregnancy are grouped into 3 classifications: presumptive, probable, and positive indications. A diagnosis of pregnancy cannot be made solely on the presumptive or probable signs because they may have other causes, listed in Table 6.2. A definitive diagnosis of pregnancy can be based only on positive signs. Presumptive indications of pregnancy. Most but not all presumptive indications are subjective changes experienced and reported by the woman. These changes are the least reliable indicators of pregnancy because they can be caused by conditions other than pregnancy. Amenorrhea. Absence of menstruation, amenorrhea, in a sexually active woman who menstruates regularly is one of the first changes noted and strongly suggests that conception has occurred. Menses cease after conception because progesterone and estrogen, secreted by the corpus luteum, maintain the endometrial lining in preparation for implantation of the fertilized ovum. A small amount of bleeding from implantation of the blastocyst may cause a woman to think she is having a period. This occurs in 30 to 40% of pregnant women. Nausea and vomiting. Approximately 60 to 80% of women experience nausea and vomiting that begin at 4 to 8 weeks of pregnancy and resolve at 10 to 12 weeks. But some women experience it earlier and longer. Although the problem occurs most often in early pregnancy, a study of over 500 women found 45% experienced nausea and vomiting during the 3rd trimester. Nausea and vomiting are believed to be caused by the increased hormones, such as HCG and estrogen, and decreased gastric motility, an effect of progesterone. Fatigue. Many pregnant women experience fatigue and drowsiness during the 1st trimester. The direct cause is unknown, but it may be from changes in hormones such as progesterone. Urinary frequency. Urinary frequency begins in the first few weeks of pregnancy and results from hormonal and fluid volume changes. It continues later as the expanding uterus exerts pressure on the bladder. Late in the 3rd trimester, the fetus settles into the pelvic cavity and causes more frequency and urgency of urination as the uterus presses against the bladder. Breast and skin changes. Breast changes begin by the 6th week of pregnancy. The expectant mother experiences breast tenderness, tingling, feelings of fullness, and increased size and pigmentation of the areolae. Many women observe increased pigmentation of the skin, such as melasma, linea nigra, darkening of the areolae of the breasts during pregnancy. These skin changes are the result of estrogen and progesterone on melanocytes. Vaginal and cervical color change. The cervix, vagina, and labia change from pink to a dark bluish purple. This color change, called the Chadwick's sign, is another presumptive sign of pregnancy. It results from increased vascularity of the pelvic organs and is present by 8 weeks of pregnancy. Fetal movement. Unlike other presumptive indications of pregnancy, fetal movement, quickening, is not perceived until the 2nd trimester. Although some women become aware of fetal movement sooner, most expectant mothers notice subtle fetal movements, which gradually increase in intensity between 16 and 20 weeks of gestation. Probable indications of pregnancy. Probable indications of pregnancy are objective findings that can be documented by an examiner. They are primarily related to physical changes in the reproductive organs. Although these signs are stronger indicators of pregnancy, a positive diagnosis cannot be made because they may have other causes. Abdominal enlargement. Enlargement of the abdomen during the childbearing years is generally a reliable indication of pregnancy, particularly if it corresponds with a slow, gradual increase in uterine growth. Pregnancy is even more likely when abdominal enlargement is accompanied by amenorrhea. Cervical softening. In the early weeks of pregnancy, the cervix softens because of pelvic vasocongestion, Goodell's sign. Cervical softening is noted during pelvic examination. Changes in uterine consistency. About 6 to 8 weeks after the last menses, the lower uterine segment is so soft it can be compressed to the thinness of paper. This is called the Hagar's sign, figure 6.9. The body of the uterus can be easily flexed against the cervix. Ballottement. Near mid-pregnancy, a sudden tap on the cervix during vaginal examination may cause the fetus to rise in the amniotic fluid and then rebound to its original position, figure 6.10. This movement, called ballottement, is a strong indication of pregnancy, but it may also be caused by other factors such as uterine or cervical polyps. Braxton Hicks contractions. Irregular, painless contractions occur throughout pregnancy. Although many expectant mothers do not notice them until the 3rd trimester, they increase in strength and frequency as the pregnancy nears term, occurring as often as every 10 minutes. It is important to differentiate Braxton Hicks contractions from the contractions of preterm labor. This is often difficult, and the woman should check with her healthcare provider if she isn't sure, has more than 5 or 6 contractions in an hour, or has any other signs of early labor. Palpation of the fetal outline. Unless the woman is very obese, an experienced practitioner can palpate the outlines of the fetal body by the middle of pregnancy. Outlining the fetus becomes easier as the pregnancy progresses and the uterine walls thin to accommodate the growing fetus. Uterine Souffle. Late in pregnancy, the uterine souffle, a soft blowing sound, may be auscultated over the uterus. This is the sound of blood circulating through the dilated uterine vessels, and it corresponds to the maternal pulse. Therefore, to identify the uterine souffle, the rate of the maternal pulse should be checked simultaneously. Uterine souffle differs from phonic souffle, the soft whistling sound heard over the umbilical cord and corresponding to the fetal heart rate. Pregnancy tests. Pregnancy tests detect HCG, or the beta subunit of HCG, which is secreted by the placenta and present in maternal blood and urine shortly after conception. Immunoassay tests are available to test blood or urine for pregnancy in a laboratory or home. They can detect HCG at very low concentrations and are positive as soon as 3 to 7 days after conception. For home testing, the woman places her urine sample on a strip or wick and watches for a color or digital change. The first morning void is preferred because it is most concentrated. Instructions vary with different tests, and the woman should read the directions carefully when testing at home. Inaccurate pregnancy test results. When pregnancy test results are reported as negative, and the woman is in fact pregnant, the results are called false negative. False negative results may occur when the instructions are not followed properly. If it is too early in the pregnancy, the urine is too dilute, or the woman is taking drugs such as diuretics. Hematuria, proteinuria, or some tumors may cause false positive results, in which the test indicates a pregnancy when the woman is not pregnant. Some anticonvulsants, anti-Parkinsonian drugs, tranquilizers, and hypnotics also may cause a false positive result. Positive indications of pregnancy. Only 3 signs are accepted as positive confirmation of pregnancy: auscultation of fetal heart sounds, fetal movement detected by an examiner, and visualization of the embryo or fetus. Auscultation of fetal heart sounds. Fetal heart sounds can be heard with a fetoscope by 18 to 20 weeks of gestation. The electronic Doppler, which is used more often, detects heart motion and makes an audible sound by as early as 6 weeks of gestation. To distinguish the fetal heartbeat from the maternal pulse, the examiner palpates the maternal pulse while auscultating the fetal heartbeat. The normal fetal heart rate is 110 to 160 BPM. The fetal heart rate is muffled by the amniotic fluid, and the location changes because the fetus moves freely in the amniotic fluid. Fetal movements detected by an examiner. Fetal movements are considered a positive sign of pregnancy when felt or visualized by an experienced examiner who is not likely to be deceived by peristalsis in the large intestine. Visualization of the embryo or fetus. Confirmation of pregnancy has become much simpler since the development of ultrasonography, which makes it possible to view the embryo or fetus and observe the fetal heartbeat very early in pregnancy. Positive confirmation of pregnancy is possible by transvaginal ultrasonography as early as 3 to 4 weeks of gestation. Psychosocial adaptations to pregnancy. Becoming a parent who is capable of loving and caring for a totally dependent infant is more than a biologic event. The process begins before conception and involves major changes in the woman, her partner, and the entire family. Although each couple adapts to pregnancy in a unique way, the psychological responses of prospective parents change as the pregnancy progresses. Although the initial reaction may be uncertainty, by the time the infant is born, the woman and her partner have completed developmental tasks, maturation steps that allow further development. These help them become parents in the true sense of the word. Both social and cultural factors influence their adjustment to the pregnancy. Maternal psychological responses. A woman's psychological response to pregnancy changes over time. Initially, she may be uncertain or ambivalent about the pregnancy, and her primary focus is on herself. Gradually, her focus shifts, and she becomes increasingly concerned about protecting and providing for the fetus. First trimester. Uncertainty. During the early weeks, the woman is unsure if she is pregnant and tries to confirm it. She observes her body carefully for changes indicating pregnancy. She may confer with family and friends about the probability and often uses an over-the-counter pregnancy test kit for validation. Reaction to the uncertainty of pregnancy depends on the individual. Usually, she seeks confirmation from a physician, nurse midwife, or nurse practitioner during the first trimester of pregnancy. Ambivalence. Whether or not the pregnancy was planned, once it is confirmed, many women have conflicting feelings or ambivalence about being pregnant. Pregnancy causes permanent life changes for the woman, and she often begins to examine expected changes and decide how she will cope with them. If it is her first pregnancy, the woman may worry about the added responsibility and feel unsure of her ability to be a good parent. A multipara may be apprehensive about how this pregnancy will affect her relationship with her other children and her partner. Ambivalence has usually changed to acceptance by the second trimester. The self as primary focus. Throughout the first trimester, the woman's primary focus is on herself, not on the fetus. Early physical responses to pregnancy, such as nausea and fatigue, confirm something is happening to her, but the fetus seems vague and unreal. Because she has not gained weight to confirm a growing, developing fetus, she often thinks more about being pregnant than about the coming baby. Physical changes and increased hormone levels may cause emotional lability, unstable moods. Her mood can change quickly from contentment to irritation or from optimistic planning to an overwhelming sleepiness. These changes may be confusing to her partner and her family, who are accustomed to more stability. Nurses should concentrate on the mother's physical and psychological needs during the period of maternal self-focus. Teaching should be aimed at the common early changes of pregnancy and their normality. Ways of coping with morning sickness, sexuality, and mood swings are important subjects to explore with the couple. The nurse should assess how the couple is managing these changes and explain that such changes are normal and generally do not indicate problems. Second trimester. Physical evidence of pregnancy. During the second trimester, physical changes occur in the expectant mother that makes the fetus, quote, real. The uterus grows rapidly and can be palpated in the abdomen. Weight increases and breast changes are obvious. Ultrasound examination allows the woman to see the fetus. During this time, she feels the fetus move, quickening. This experience is important because it confirms the presence of the fetus with each movement. As a result, she no longer thinks of the fetus as simply a part of her body, but now perceives it as separate, although entirely dependent on her. The fetus as primary focus. The fetus becomes the woman's major focus during the second trimester. The discomforts of the first trimester have usually decreased, and her size does not affect her activity. She is now concerned about producing a healthy infant. She is often interested in information about diet and fetal development. A feeling of creative energy and satisfaction is common. Narcissism and Introversion. At this time, many women become increasingly concerned about their ability to protect and provide for the fetus. This concern is often manifested as narcissism, undue preoccupation with oneself, and introversion, concentration on the self and body. Selecting exactly the right foods to eat or the right clothes to wear may assume more importance than earlier in the pregnancy. Some women lose interest in their jobs, which may seem alien compared with the events taking place inside them. If this is her first pregnancy, the expectant mother wonders about the infant. She looks at baby pictures of herself and her partner and may want to hear stories about what they were like as infants. Although multiparas know more about infants in general, they are interested in this infant and concerned with the child's acceptance by siblings and grandparents. Expectant mothers also may examine their relationships with others and how these ties will change after the birth. The woman often spends much time thinking about the fetus and daydreaming or fantasizing about what life will be like when it is born. She may call it by the name chosen and talk about the personality of the fetus. Some mothers enjoy reading about fetal development to see what changes are happening each week. This intense introspection may be confusing to her partner and family because it is so different from her usual behavior. Body image. Rapid and profound changes take place in the body during the second trimester. Changes in body size and contour are obvious with thickening of the waist, bulging of the abdomen, and enlargement of the breasts. Changes may be welcomed because they signify growth of the fetus and give the woman and her partner a feeling of pride. They increase the woman's body image, subjective view of self. For some women, however, the change in body size and shape, coupled with hyperpigmentation of the skin and striae gravidarum, may contribute to a negative body image. Changes in body function such as altered balance, reduced physical endurance, and discomfort in the pelvis and lower back areas may also affect her body image.